Okay, I think we'll get started now. So good afternoon and welcome. Thank you for taking time out of your busy day to join us here today at this webinar. My name's Sadie Burling and I'm the National Head of Aged Care for BestMed, an electronic medication management system. And joining me today, I have Dr. Natalie Salisbury, Head of Clinical Development for WardMM. Before we get started, I would like to begin by acknowledging the traditional owners of the land on which we meet today. I would like to pay my respects to elders past and present, and I extend that respect to Aboriginal and Torres Island people who may be present today. So before we get started as well, just a little bit of housekeeping. You will note that at the end of the webinar, we will be providing you with a slide deck and recording of the presentation, some posters, and you'll also notice at the bottom of your screen, there is a question and answer button. Try not to use your chat button, but your questions and answers so that we can capture all your questions and provide answers either at the end of the webinar, or if we don't get time, we will send out a question and answer sheet with our slide deck. So next slide. So you can see the objectives of the session there, but basically what we want you to take away from today is a thorough understanding of what a residential medication management review is and how it intersects with electronic medication management systems, but more importantly, how you, through RMMRs, which are the residential medication management reviews, can improve the quality of your consumers' or residents' life within an aged care service. So without further ado, I'm going to hand over to Natalie, and you can go to the next slide. Thank you.
Thank you very much, Sadie, and thank you very much for the opportunity to be present at this webinar and working with you, and also welcome to everybody that's joined us today. Very much appreciate you giving up your time. So I'm just going to kind of briefly go through what an RMMR is, and we love our acronyms in the world of health, as we all know. So I will call residential medication management reviews RMMRs from now on in. It's actually a means for an accredited clinical pharmacist, and I will talk a little bit more about who that is and what that means in a moment, to work with the GP to do what we call a kind of, I suppose it's a checkup on the medications that the individual is taking. And it's really about, as one of my GPs used to say to me, making sure that they're not trying to kill the patient. Because in reality, often what we see is people on multiple medications. And when we start digging into what's going on, they've actually been put on these medications because of side effects of other medicines they're already taking. We can provide these services into the aged care home, and that's obviously what we do. Obviously our preference is to go into the home to provide the services. With COVID, we have been given the opportunity to do this via telehealth, but ideally doing things face-to-face is obviously the best option for us. We tend to be independent of the supply pharmacy to be able to provide the medications into the homes. And the service itself is actually a government-funded service through the 7 community pharmacy agreement. Could I have the next slide, please? So who can actually conduct a medication review? And as I alluded to before, it's somebody that's an accredited clinical pharmacist. And who are we? We've been given many titles over the years. We could be called a consultant pharmacist, a review pharmacist, or a DMMR pharmacist. We are experienced registered pharmacists, and we have to get a second credential to be able to provide these services. And there's 2 options and two ways that we can do this. But both of these credentials allow us to provide medication reviews into aged care homes and also into the community setting. But it also means that we have to do extra CPD to be able to maintain our accreditation, and we also have to re-accredit. So it isn't a qualification for life. We do have to keep up to date. Next slide, please. So I did talk before about the 7 community pharmacy agreement. And this is the agreement whereby we can conduct these medication management reviews. It's actually negotiated every 5 years, and the last one was negotiated in July of this year. And what the new agreement has shown is what we call the importance of the cycle of care. So prior to July of this year, we were able to do one medication management review every 24 months. Now, if you think about the people that are in your aged care home, and from the data, what we know is that the majority of people that are coming into an aged care home now have obviously got a higher acuity level and might not be alive in 2 years' time. So the reality is a medication review every 24 months is a really pretty much of a pointless exercise. So what the new agreement did recognise was this was an issue, and that the reality is we should be able to do these reviews more frequently, providing there was a need, and I'll talk in a little bit more detail about the triggers for the medication reviews later on. But what we were also able to now do is provide follow-up. So that means that the recommendations that we've made for the medication reviews allow us to then do 2 further follow-ups just to assess whether or not A, the recommendations have been taken up by the GP, and if they have, that there's been no harm come to the resident by those medication changes happening. Next slide, please. So I'm sure all of you in the audience, sorry, can I have the next 2 bits as well, please, Surinder? Just to bring it up, thank you. I'm sure there's nobody in the audience that hasn't seen or heard of what I'm about to say now, but really it's just emphasising the importance of the fact that we know that medication harm is a significant problem. And we also know that the Royal Commission into Aged Care did identify medications as a hot topic. And so as a consequence of that, it's very important that we do look at people's medications. And we also know that it costs the country about $1.5 billion an annum for people that have potentially a preventable medication related harm that brings them into hospital. And from the data and the research, we know that around 2 in 3 people aged over 75 will be taking 5 or more medications. So it's a huge number of people taking a large number of medicines, potentially causing harm. Could I have the next slide, please? Sorry, my mouth gets really dry when I present, so you'll have to forgive me having glugs of water every so often. So who can get a medication review? So the government have stipulated that the individual has to basically be an Australian resident, so have a Medicare or a DVA card holder. They have to be living in an aged care home. However, there is a small caveat to that. If that individual is part of the transition of care process and have been in the home for 14 or more days, they are also eligible for a medication review. And then there has to be a reason why we might want to do a medication review. So one reason could be a new admission, and I will talk about the reasons for a medication review in a little bit more detail later on. But the GP also has to confirm the reason for the medication review. And the Royal Commission in their report did say that all new residents into an aged care home should have a medication review as a matter of course. So it shouldn't necessarily be something that is up to the GP to make a decision about. They're advocating for every resident who's new to the home to receive a medication review.
Natalie, can I just stop you there for a moment?
Sure, Sadie.
I'm sure that we've got some people in the audience who actually go into residential homes. Is there an opportunity if they identify or have concerns about what medications residents are on in their own home to have an RMMR done?
There is an opportunity. It's called a HMR, so H for Home Medicines Review. But absolutely, if a carer goes into a home and is concerned about that individual's ability to manage their medications, or thinking they might be having a side effect from their medications, they're absolutely well within their rights to bring that information and concerns not only to the family member and the person themselves, but also to alert the GP so that the GP can consider whether or not they would value a home medicines review for that individual.
Good to know. Thank you.
You're welcome. Next slide, please. So I've got a couple of slides on what there are that are triggers for a medication management review. I'm not going to read through all of this. You'll obviously get the slide decks yourselves and can go through them in your own time. Suffice it to say, the main triggers would be considered those that are a new admission, as we mentioned before, into an aged care home. And then identifying a clinical need. So has that individual had a change in their clinical status? So have they gone from being able to take their medications whole to needing them to be crushed? Have they just come out of hospital? And that transition from the hospital setting into the aged care setting can be a time of most vulnerability for those individual residents. So that would also be a trigger for a medication review. If there's been newly prescribed medications, changes to the regimen that their individual's taking, that also could be another reason for a medication review. Next slide, please.
So Natalie, just before you go on, just going back to the home care space again. So if I was visiting somebody and I identified some of the triggers that you've been talking about, I'm assuming that I'd be well within my rights to request a home medication review. But if I do that, who actually appoints the clinical pharmacist to undertake that for the resident?
So that's a very good question. There's a number of different ways that can happen. If it was in the aged care home, all aged care homes should have an accredited clinical pharmacist providing these services already that's got that contract. So that would be the person that they would go to. In the home setting, it's a little bit more complicated. If the GP knows an accredited pharmacist, obviously they can refer directly to that individual. Often what tends to happen is that the GP would potentially refer through the community pharmacy that the person goes to pick up their medications, and the community pharmacy tends to then either have somebody themselves that works for them or with them that can provide that service, or contracts that out. So they may know other accredited clinical pharmacists that they could get in touch with and say, look, we've got an HMR for Mary Smith, for example. Are you able to do that for us?
Okay, thank you.
Next slide, please. So how do you organise an RMMR? So there are a number of different ways that this can happen depending on how you have your service arrangement with your accredited clinical pharmacist. But primarily, the first thing that needs to happen is, well, not the very first thing, but one of the things that has to happen before we can do the medication review is we need to get consumer consent. Now, up until quite recently, the form that the resident filled out when they came into the aged care home, which gave permission for their information to be shared with other healthcare professionals, meant that we didn't need to get a formal consent from them to do their medication review. However, the PPA, who are the pharmacy program administrators, i.e. the people that hold the money that pay us and ensure that we follow the rules of the reviews to the letter, decided that because they are going to be getting demographic data from us when we send in our claims and potentially going to be auditing people, they needed to get permission from the resident for that information to be shared with them. So now we have to get a formal consent from the resident or their substitute decision maker in order to be able to conduct the medication review. So we can't do the review without that. We also have to get a referral from the GP. So it is frustrating from that perspective, because that can often be a barrier to us receiving the referral request or doing the review. And it can't be a nurse practitioner. It has to, at the moment, it's just got to be, it's only the GP that's allowed to do it. So a referral request will be sent through to the GP, and this can be done a number of different ways depending on what you've got organised with your, as I said, accredited clinical pharmacist. What we do at WardMM is we would have the resident will be identified, then we've got our own referral form that the nursing staff can then fill out and send to the GP. Or if we know it's a new admission, we can automatically generate one and send one through to the GP. The GP gets the referral form, however, they do get it. And sadly, we still seem to use faxes in this day of technology, but they seem to be the way to go for the GPs. And as we all know, if you've ever been into a GP practice and listened at the reception desk, often all you can hear in the background is the fax machine going off. So it's a very busy place for them. The GP gets the referral request form, signs it, but they have to identify why they want the medication review to be conducted. So again, they need to make sure that they tick the box or write why they want the review. So what the need is for the medication review to occur. They send that back either to the home or to the clinical pharmacist, depending on what system they've got set up. And then we would arrange to go and do the medication review.
So Natalie, if you had an electronic medication management system that had a communication link to the GP, could you just send a communication via that, or are you still required to complete the request form?
So you absolutely can send a communication that you would like the person concerned to have a medication review, but we still need a signed request from the GP. So
Right.
as I said, we've got our own forms that we've created for the GP to sign off on. You don't need a specific form, but you do need the GP to say, I would like you to conduct a medication review for Mary Smith of X home, because she is a new admission, or because she has had a change in her clinical condition and now requires crush medications, or whatever that change in clinical condition is, or whatever the other trigger might be for them to actually have that medication review conducted.
Okay, thank you.
That's okay. And so next slide, please. So this really is just sticking my accredited clinical pharmacist hat on and just walking you through what is it that we're doing when we're in the home, and what are we trying to achieve, and how do we go about it. So we've come into the home, we're going to conduct the medication review. We need to collect information about the individual. So we need to think about who that person is, what their goals of care are, talk to them if we can. I mean, obviously, if they're not cognitively intact, we can't always have that conversation with them. If we can't talk to them, talk to a family member. If the family member is not contactable, talk to the nursing staff and carers in the home, just to find out what their concerns might be about that individual, but also, as I said before, what the goals of care are. And then we can start thinking about what it is we're trying to achieve for that particular person. Once we've got that information available, then we start looking at things like the medications they're taking, their diagnoses, the pathology, any letters from specialists, any discharge information from hospitals, those sorts of things, to try and paint a really holistic picture of that individual. Because what we want to make sure is that our reviews are patient-centered. It's got to be about that individual. It's not about, oh, this person's on this, so we're going to do that. It's really about what's the individual taking that medication for, and is it still a requirement? Is it essential? So is it a need to have, or a nice to have, or a want to have? And the other thing, obviously, to take into consideration is whether or not they're married to their medicines. And I use that term lightly, but sometimes when you're having conversations with these individuals, as much as we know that medication might be causing them harm, they don't want you to stop it. Oh, you can't stop that medication. My doctor told me I had to stay on it forever until I die. And it's almost like, well, if I take you off it, you're going to die tomorrow. And clearly that's not going to happen. But we do have to be mindful of the sort of individuals' goals of care, and also their concerns and what they think about their medications. Having said that, there's plenty of people that we talk to that say, take me off everything, or take me off as much as you can. I hate taking the pills. So we gather all the information. We then think about what it is that we want to achieve for that individual, start taking things into consideration. Then we have all of our information together for the review. We think about the issues. We think about what we're trying to achieve, which is optimizing their pharmacotherapy. And then we think about our recommendations, and we put all of that together into a report that gets sent to the GP. And a copy would also go to the home as well for them to keep. Next slide, please.
So Natalie, just before you move off, I've got a question.
Well,
how often do GPs take up your recommendations, or more importantly, how often do they not?
That's a very good question. And I would have said up until around 12 months ago, I would have found that a really difficult question to answer. We do keep a record of our GP feedback when it gets sent in to us. But oftentimes the GP feedback is left in the nursing home, so we don't always necessarily see a copy of it. And because we weren't able to do follow-up reviews, it was often quite difficult for us to potentially be able to see if there'd been any medication changes. Now that we can do follow-up reviews, our most recent data, so the most recent data that I had a look at was from January to May of this year. Around 50% of our recommendations are taken up by GPs currently after the first follow-up review. So at least we have a benchmark at the moment. It would be great if it was more than that, but that at least we've kind of got an idea as to where we're sitting currently. And then we can start looking at how we can be adding more value to the reviews that we're conducting and getting more buy-in from the GPs with our recommendations and getting more collaboration with them.
So do you think that's improved over time, but particularly since the Royal Commission? Do you think you're getting more uptake of RMMRs?
Certainly more, I would say more uptake of more transparency over the uptake of our recommendations, I would say. And I think it's because we can do the follow-ups. If the GP hasn't taken this up on our recommendations, there are things that we can obviously do with our follow-up review. So it might just be a gentle nudge asking them to confirm that they don't want to make those changes. It may be, you know, to be honest, they never even got the first report initially, because it was faxed through to them with a big pile of everything else they've got in the fax machine, and they never actually got a copy of it. So it does give us opportunities to identify what might be happening and why they might not be making those changes.
Okay, thank you.
That's okay. So we've talked about there are an awful lot of triggers for a medication review, but I just wanted to focus very briefly on the polypharmacy one. And the reason why I wanted to talk about that one is because it's one of the new mandatory quality indicators, as I'm sure you're all aware. And the QI itself says 9 or more regular medications, but not all medications are included in that count. And so they don't want you to include things like creams and vitamins, amongst others. And there are a number of us in conversation at the moment around the value of this particular QI, because in reality, if you have a vitamin deficiency and require that as a treatment, so for example, vitamin D deficiency, I personally believe it should be included in the count because it's being treated for a diagnosed condition. So I think this is very much around watching this space. But ultimately, what we're trying to achieve when we're doing our medication reviews is identifying the drug and the diagnosis. So we look at what medicines people are on, what their diagnoses are, and we marry everything up. And this is what I call clinical pharmacy 101. So drug, diagnosis, does it match, yes or no? If the answer is yes, that's great. And then the next question we ask is it appropriate for this individual, depending on where they are in their journey of life, if you like. And then we start looking at the drugs that are being prescribed without an obvious diagnosis, and also vice versa. And sometimes medications might be missed on admission. Sometimes there's been a decision over time to cease medications. And that's something obviously that we need to be made aware of, so that we won't then make a suggestion to start a medication that's been ceased. So really, we're trying to make sure that we improve the individual's quality of life, because what we don't want people to do is be having side effects from their medications, ending up on more medications. And we call this the prescribing cascade, because ultimately, we know that medications can cause harm, and we just need to be mindful of, as people get older and frailer, they're far more at risk of medication-related harm. And we really want to just be able to make sure that the medicines they're taking are appropriate for them. So that's sort of why I wanted to kind of focus a little bit about the polypharmacy, and to ensuring that, you know, those individuals are on the right medication for the right reason. Next slide, please. So as an organisation, what barriers are we seeing to people taking up the whole concept of an RMMR? And I've listed some of them here. I guess when they changed over to us needing to get consent, our biggest barrier was definitely getting consent, because that was something new for us. For those of us that do home medicines reviews, we've always had to get consent. So the form was not an issue, but ultimately in an aged care environment, you know for a fact that around 50% of the residents in there are not going to be cognitively able to understand why you're getting them to sign a piece of paper. So then you've got to go through the whole rigmarole of getting in touch with the next of kin or whoever it might be to get them to give consent. So that's obviously very time consuming, and was definitely a barrier to being able to get the medication reviews. Having said that, you know, it's been a while now, so we've sort of got used to the whole concept of doing that, so it's a less of a barrier. But there are things like GPs having had a poor review from a previous pharmacist and being put off the whole concept of a medication review, thinking they're a waste of time. The fact that we couldn't follow up on the review, so it meant that it was like a once in a lifetime opportunity, and then nothing really came of it, and the GPs didn't see the point. Sometimes it's the family not understanding what we're trying to achieve. And as I said before, we're not trying to kill the person off. And it's really about ensuring that they've got a really good understanding of what we're trying to hear, what we're trying to achieve in all of this. So we just need to make sure that as people are getting older, that the medications that they require are still of added value. So we look at the risk versus the benefit of those individual medications for the individual themselves. So if we think about, as an example, things like a statin. So we know that statins are very valuable medications that helping reduce the risk of having a cardiovascular event, but that's really looking at 5 years in the future. So if you've got somebody who's into their 9th decade of life and they're still taking a statin, we have to ask ourselves the question, are they getting value from that medication versus the side effect potential that they may be experiencing from that medication? So we start thinking about those sorts of things and start thinking about whether or not it's appropriate that they should stay on those medications, or whether or not we can start looking at taking them off those medications.
Natalie, you've talked about many barriers there, and I'm sure that the audience, along with myself when I was a clinician, came up against those barriers. Do you have any strategies that you have implemented to overcome them, or could any pearls of wisdom, I guess?
For me, it's all about communication, and that is the biggest barrier, is a lack of understanding of what we're trying to achieve here. So one of the things that we advocate is we have an information leaflet which is all about medication reviews, and we have those in the admission packs for our residents when they come into the aged care homes that we provide our services into. They're also available to be handed out to the residents and their family if they need them. Going to resident relative meetings to talk to them about medication reviews and what they mean. Making sure that you communicate with the doctors, so finding out when the doctors are going to be in the home. Obviously again, that is a barrier. If they come at 10 o'clock at night, you don't necessarily want to have to do that, but ultimately introducing yourself to the GP, getting a better understanding of who they are and having a good relationship with the GP, again, is really valuable. We do send out information to our GPs on a regular basis to try and get them involved and get them to understand what we're trying to do with our medication reviews as well. So yeah, for me, overarching, it's about communication.
Natalie, just before we move off, we've got a question from Ivanka in the audience, and she said that she was not sure if this was covered, but how many RMMRs can be done in a year per patient, which is covered by Medicare, and is it covered by Medicare?
So the GPs are covered by Medicare for conducting a medication management review, absolutely. It's item number 900 or 903, depending on whether it's a home medicines review or a residential medication management review. The Medicare covers them for one every 12 months. However, if there is a clinical need, they can be done more frequently than that, but the GP has to annotate their claim with the reason for why they've actually asked for that review to be conducted more frequently than a 12-month time frame. So hospital, for example, discharge from hospital is an absolute trigger for a medication review, and that would definitely be reimbursed by Medicare as long as the GP annotated their claim with that information.
Okay, thank you. Next slide. I think it's over to me now.
It is. It's over to the lovely Sadie. I can be quiet for a few minutes.
Okay, thanks, Natalie. So I'm not going to read this slide. You all know this slide is straight off the department's website, and I'm sure that you're all across the requirements of consent. But just to confirm, good clinical practice ensures that informed consent is obtained at the appropriate time. Informed consent must be obtained before any treatment, medical or otherwise, is provided or given. And remember, consent is obtained and remember, consent is a key issue of the Quality and Aged Care Commission, and it's contained under Standard 1. So you should all be across that. And I know, Natalie, that you talk about consent quite a lot through your presentation. So I think you mentioned before that you do have to get consent and that there is a special form, but whose responsibility is it to obtain that consent?
So as I said before, Sadie, it is actually the responsibility of us as the clinical pharmacist providing the medication review to ensure that we have consent. However, ideally, from our perspective, to streamline our work, it would be great if we could get the homes to help support us to get consent. So by identifying those residents that are not cognitively intact allows us to then contact the family members to gain consent that way. And then for those residents that are cognitively intact, to gain consent either when we're there in the home, because obviously we're going to go and talk to them. But sometimes, it's great if we can get that ahead of time, because then at least we know that the resident is going to be there and available for us to do our medication reviews. So there are a number of different ways that we can gain consent, but ultimately it's up to us to make sure we have the consent. Because to be honest, we won't get paid if we don't. I mean, that's the bottom line. So, we have to be realistic about all of these sorts of things. And that's why it was so, I suppose, so painful really when it came about. We got 12 hours notice. It was this like fait accompli. You've now got to start getting consent. Oh, and by the way, you've got to use this particular form. Oh, and the forms that the residents have signed before aren't good enough. So, it was a bit of a kind of sea change for us for all of us that are accredited pharmacists to actually be able to make those changes and start getting the consent.
Thanks, Natalie. Can I have the next slide, please? So we're all familiar with this slide, of course, and this is about the standards. And we believe that we needed to pop this in so that you knew where medication management and RMMRs sit from our perspective. So we believe they sit under standard 2, 3 and 8. And we already know consent sits under standard 1 and possibly standard 8 as well under governance. So we believe medication management falls under assessment and planning, the provision of safe and effective care, the inclusion of other organisations such as WardMM and such as your electronic medication management provider, such as BestMed, may be included in the consumer's care, so that they are we believe, fit very nicely here. Care services are regularly reviewed and effectiveness, and when circumstances change. So this is where an RMMR plays a very important role in managing medication management. So when you notice that a resident's had a change, as Natalie's gone through all the different reasons why you would go for an RMMR, this is where it sits nicely under standard 2. In terms of standard 3, each consumer gets safe and effective clinical care, and it is tailored to their needs. Again, that's what an RMMR is doing. It's tailoring the medication management or the medications that they're consuming to their actual needs and making sure that they're appropriate for the resident. We all know that inappropriate medication can lead to adverse effects, hospitalisation and even death. So medication management systems and RMMRs can assist in effective management of high impact, high prevalence risks associated with medications. So once again, RMMRs can identify when there are medications that don't actually work well together, and that's where Natalie comes in as a clinical pharmacist. She can easily identify that, and then there'll be a discussion with the prescriber over whether or not they need to continue it or think about a different type of drug. Medication management systems can also assist to improve the practice and promote appropriate antibiotic prescribing. So you know that you are required to have good antimicrobial stewardships in place, and medication management systems can help you with that through the reporting systems. And again, that highlights issues to the RMMR process. The other area that medication management and RMMRs can help in is the deterioration or change in a consumer's mental health, cognitive or physical condition is recognised and responded to in a timely manner. For example, a resident may be acting out or behaving badly and you have no idea why. So the first thing you should do before you go and ring the prescriber is have a look at the resident's behaviour support plan. Have those behaviours been identified, and have there been strategies put in place to identify them? And if not, they might be new behaviours that you need to address. So one of the things you would do is perhaps go and look at the last time the resident had their bowels open. They could be constipated and be in pain and acting out. So a simple aperient might fix that problem. They might be in pain, be non-verbal and can't express themselves. So the only way they know how is to have a responsive behaviour that is not common for them. So you might have a look at doing a pain check on them and just seeing what's going on there. They might have an underlying infection. So you might need to do their vital signs and just check out what's going on there. Or ultimately, it's a behaviour that needs intervention with a medication. But what I'm saying here is that a good clinical assessment and then a good review of the resident's medication. Oh, I should have said that you should review the medication chart, because the resident might have been put on a new medication that's having an adverse effect. So that might trigger another RMMR for the resident, or you might be contacting the prescriber to introduce a restrictive practice, but that should always be as the last resort. So, and under Standard 8, it's about having robust governance systems in place. For example, having MAC meetings that have a standing agenda item for RMMRs, looking at your polypharmacy reports and looking at your antipsychotic reports and your psychotropic registers should all be through your MAC meeting, where you can have a really good overview of what's going on in your service and across your services if you've got multiple homes. It's also about having robust systems to manage high impact, high prevalence risks. And this is where an electronic medication management coupled with RMMRs can support you. Ultimately, your aim as service providers and our aim is to support consumers to live the best life they can. So next slide, thanks. So as Natalie alluded to before, we would all be familiar with these two indicators now, which were introduced in July of this year. So we're required to report on polypharmacy, 9 or more medications, as Natalie's mentioned, and that is to be collected on a particular day in a three-month period. And Natalie's already talked about how polypharmacy can be a trigger for an RMMR and the reasons why. So I won't go into that again. The other indicator was around antipsychotic medications, the percentage of antipsychotic medications a resident may be on, and that is collected in a 7-day period in the quarter, usually the second week of the quarter to the end of the quarter, and it's over a 7-day period. So a good electronic medication management system with robust reports can assist you with the press of a button, getting these reports out without having to wade through multiple charts to get your answers. And the answers will be correct because it's all in real time. So you're not going to have any lag indicators. It's all going to be in real time at that point in time. Next slide. So we come to SIRS, and you might be asking, why have we got SIRS in here? Well, we all know that we have been required to report on adverse outcomes to the department for a very long time, but we now have a name and criteria on reporting requirements. There are now 2 sets of priorities with different requirements on when to report. Under priority 1, there are 8 categories for reporting, of which inappropriate use of physical and chemical restraint is one. Hence why we are mentioning SIRS and the importance of your psychotropic register. I can tell you that between the 1st of April and May 12 of this year, there were 22 reportable matters relating to this category. An example of inappropriate use of psychotropics could be around the lack of consent, used in non-emergency situations, using a medication for a consumer as a form of restrictive practice without following all the requirements, having a behaviour support plan that is not really holistic. It's not identifying the behaviours or the triggers that have occurred for that resident. So using a med management system that has a robust reporting reports and tools will assist greatly in you meeting the requirements in response to restrictive practices. But before I move off here, Natalie, can I just ask you a quick question? From an RMMR point of view, how do you see that linking into the SIRS?
Well, obviously conducting RMMRs will help hopefully reduce the serious incidents, because we can identify those residents on high risk medications. So if somebody, for example, is a high falls risk, we can have a look and see if any of the medications they're taking could be contributing to that. So there are many drugs that can cause things like blurred vision, for example, or can cause orthostatic hypotension. So when they stand up, they feel dizzy and are at risk of falling over. And we can sort of hone in on those medications and make suggestions about either stopping them, dose reducing them, or changing them to something else if they're essential for them to have a medication for a particular indication. So I think it just gives us an opportunity to work closely with the homes in identifying those at-risk residents and reducing, hopefully, the risk of medication-related incidents.
Fabulous, thank you. I think it's over to you again, Natalie.
I think it is. Thank you, Sadie. Next slide, please. So a little bit like Sadie, I'm not going to read through this slide. Everybody talks about deprescribing. I personally don't like the term deprescribing. I think it sounds like some kind of disease. So I call it appropriate medications, because the reality is the role of the accredited clinical pharmacist is to be looking at the appropriateness of those medications for the individual. And as I mentioned before, it's all about risk versus benefit. So once we know about the goals of care for that individual, we can start looking at whether or not they need to stay on the medications that they're currently being prescribed. So the whole concept of a good appropriate medication practice is really marrying all of those things up together, working with the family, the resident themselves, the nursing staff in the home and the GP to collaborate together to have that holistic approach to the care of the individual, and it can help improve the quality of their lives. And when we start talking to individuals, most people would rather live a good quality of life than a longer quantity of life if they're feeling pretty miserable. So that's one of the reasons why the whole concept of an RMMR and looking at the appropriateness of the medications is an incredibly valuable opportunity for us, for the residents. Next slide, please. So this is just some data that I wanted to share with you briefly. We put in a submission to the Royal Commission, and this was an updated submission that we put in after the follow-up reviews were initially brought into play, which was of July this year. And this really just shows the top 5 reasons for the initial medication review. And as you can see, when the follow-up reviews were first came about, the main reason why we conducted a follow-up medication review was because they were on an antipsychotic or a sedative. And interestingly, I went back to have a look at our most recent data just to see what sort of changed. And we, up until May of this year, we'd done about 2,500 follow-up reviews. And what that was showing us was it was actually the new admissions were the ones that we were primarily following up on, followed then by people that were on high risk medications. So we sort of lumped antipsychotics and sedative medications and high risk medications into one group. And we're definitely seeing that that was a definite trigger for following up on a medication review that we'd done initially. Bearing in mind, one of the things about making recommendations is thinking about the reality of what you're trying to achieve. So, you know, if you've got Mary, who we're going to meet in a moment, but this is a different Mary. If you've got a different Mary and she's been on temazepam for 40 years, the chances of you getting her off that temazepam are fairly remote. And so we have to be realistic about what we're trying to achieve in our goals of care here. And look, if she was falling over and we were concerned about that was one of the triggers was the fact that she was on something like temazepam, absolutely you'd want to try and get that individual off that medication. But if they're married to the drug and they're not having any adverse effects from it, it's a battle that you might not necessarily win, and you have to ask yourself if you actually want to have that battle. So we just need to be realistic about the targets that we're trying to achieve in our goals as well, and what we're going to, you know, get for it from the resident and for the resident.
So Natalie, just before we move off, I think I would be correct in saying that electronic medication management systems gives you, as a clinical pharmacist, visibility on all residents who are on antipsychotics or sedatives, as you've mentioned. Would that would go a long way in assisting you in making recommendations and informed decisions before for your report. I think I would be correct in saying that having an electronic medication management system, therefore, is much more efficient and effective in getting that detail that you need to make those recommendations, would I not?
Yeah, I mean, I guess the thing about an EMMS is that, number one, all the information is completely clear. So we never have to worry about what on earth has that GP written. And we have a WhatsApp group at work, and we constantly are asking questions, taking photographs of drug charts, saying, or just not the whole chart, obviously, just the name of the medication. What does this say? Because sometimes the GP's handwriting is atrocious, and what you don't want to be doing is guessing. And yes, of course, you can obviously go and have a look at the sachet or the Webster pack or whatever it might be to double check. But what happens if it's a non-packed item? You wouldn't necessarily have a clue what it might be that you're looking for, even in the trolley. So having something like an EMMS means that you're never going to have, there's never a grey area in the context of what medications have been prescribed, what the doses and the dosing frequency, which is really valuable. And the other great thing about the EMMS is that at the touch of a button, you can go and have a look at the individual who you've done the initial review for and see what the medication chart's now saying, and has there been any changes. And it's really easy for you to identify what those changes are. So there is a value in having a system whereby, which it just simplifies things for you, because you're not trying to decipher GP's handwriting or looking at scruffy charts and things like that. I mean, over my years as a pharmacist, which is far too many, I've seen some dire charts and some terrible writing, and they just look like somebody's poured coffee over them, and they're just a mess. Whereas this way, that never happens.
That's an advantage I never thought of.
That's why I can't spill coffee. Well, mind you, if you spill coffee over the laptop, you're stuffed. So let's hope that doesn't happen. Next slide, please. So in the last sort of section of this session, what I wanted to do is run through a scenario with you. And I've talked about Mary a lot. So this is Mary. I would like you all to meet Mary. As we talk about Mary, I am quite sure that everybody on this call has met a Mary, probably already knows a Mary, and I would suspect has at least one in your home. What we did as an organisation was we had a bit of a sweep, and we wanted to try and find which resident had we done a medication review for that was on the most medicines, and Mary won. So I wanted to sort of talk you through Mary, talk about the medications briefly that she's taking, talk about some of the recommendations that we made, and talk about the outcomes. Now, I just have to caveat that Mary is very complicated. We did do follow-up reviews for her because we could. We also did a case conference, and oftentimes case conferencing is an amazing way of improving GP relationships, improving the relationship that you have with the staff in the home, but also allowing you to get instant, if you like, confirmation of the recommendations that you've made, and also assessing and addressing other issues that might need to be followed up on. And then you can potentially do another medication review because you've identified new issues. Anyway, so this is Mary. She's got atrial fibrillation, heart failure, type 2 diabetes, she's depressed, she's got high cholesterol, swollen ankles, bit of osteoarthritis, asthma, gout, breast cancer. And she now requires 24-hour care. So the family had to make the big decision to move her into an aged care home. And that's what happened to Mary. And upon admission, her GP, because he's so proactive, decided to ask us for a medication review. Could I have the next slide, please? Now, these are just Mary's regular medications. Now, I'm not going to test anybody on this, and I do not expect any of you to read all of it, but it was really just to show you the fact that she was on 18 different tablets, a puffer. She was also on sachets and liquid for constipation, so Movicol sachets and lactulose for constipation. She was also on warfarin. She was having a very interesting insulin regimen of 5 lots of insulin every day. So she was having a long-acting one morning and evening, and then pre-meal ones each meal. And she had 10 PRM medications prescribed. Now, I didn't list those because I just couldn't face doing that. I was like, this is enough. This is enough to discuss in the session about Mary. So obviously, one of the things that you want to do is find out from Mary what her goals of care are and what her concerns are. So that was what we did. Next slide, please. So the home also confirmed this, that Mary hated taking all the tablets that she took. And so we have to obviously listen to what we think the patient or resident is concerned about and how we can help address those concerns. Could you just click on that for me, Surinder, please? So as I said, she was vocal about the amount of medication she was taking. She doesn't want to take as many. So yes, absolutely. The conversation we had with her was, can we achieve this? I think we can. She asked the question that she's taking quite a high dose of water tablets because she's got heart failure, but her ankles are still swollen. Next click, please. So obviously, as a clinical pharmacist, the first thing you have to ask yourself is, are any of her medications contributing to the swollen ankles? And no matter what we do from the point of view of giving diuretics, oftentimes depending on what the causation is of the swollen ankles, we might not get rid of the swollen ankles. And so she's on a couple of medications, both the gabapentin, which she was on for nerve pain, and mirtazapine, which was on for her depression, can cause peripheral edema. And it's not responsive to diuretics. So the reality is, can we stop these medications and see what happens? She didn't complain of pain. So because her pain was well managed, it was certainly something that we could take into consideration. She's moved into an aged care home because she does need quite a considerable amount of care. However, she still wants to go out with her family for coffee or lunch or whatever it might be. But she does get anxious because she doesn't like running to the toilet. And because of that, she feels she can't be out for too long. Now, I do heart failure education, and I have to tell you, everybody I know, when I do my educations that has heart failure, they can tell you where all the public toilets are whenever they go out. Now, if somebody's in a new environment and doesn't know where the public toilets are, they might get quite anxious about that. So obviously we need to take all of those things into consideration. Next click, please. So she's on furosemide and also hydrochlorothiazide. So she's on what's called a loop diuretic and a thiazide diuretic. And the combination together, the hydrochlorothiazide, so the thiazide diuretic will potentiate the effects of the loop diuretic. So really it's making a furosemide work better, if you like. And maybe one of the things that we can look at is, does she need to be on the hydrochlorothiazide? And that might mean that she doesn't need to take that anymore. That might be a possible option for us. But also, does she still need the big dose of furosemide that she's taking? And is there any way that we can rein that dose in? So in somebody who has heart failure, we'd want to make sure that they were at their dry weight. We don't want them to be dehydrated, but we don't want them to be fluid overloaded either. So that's the sort of thing that we would be looking into to find out what her goals were, what her weight goal was, and whether or not we could start looking at making those changes for her. The other thing that she complained about was the taste of lactulose. Now, I don't know if any of you have tasted lactulose. When I was a baby pharmacist, we were made to taste all liquids that we were potentially going to sell or recommend to patients to buy, or even recommend to doctors to prescribe. So my background is as a clinical pharmacist in hospital. So it was in the hospital setting that they made us do this. And I have to tell you, lactulose is disgusting. It's really sweet and sickly. It's vile. And I'm not surprised when Mary said, I don't like the taste of it. It was like, yeah, totally get it. And obviously, well, not obviously, because iron tablets don't always cause constipation, but her constipation had got worse because she was taking the iron tablets. Next click, please. So one of the things that we can obviously do is check her iron studies and her hemoglobin, and just see whether or not the iron tablets need to be continued. If they don't need to be continued, then we could probably stop the lactulose as well as stopping the iron tablets. Or can we change the lactulose to something more palatable for her if she still needs to take it? And then she just complained about aches and pains. I mean, I know when people get older, they often complain about aches and pains anyway, and they talk about wanting painkillers. And I absolutely hate that term, because ultimately, As a very eminent anaesthetist once said to me, Natalie, there's only 2 ways we can kill pain. We anaesthetize you or you're dead. Now, obviously, we want to do that to anybody unless we absolutely have to. We certainly don't want to kill anyone. But ultimately, I think we just need to dispel the myths about what analgesics are there for and what they can achieve. But we also need to be mindful of, can medications be contributing to people's pain? So we know, for example, that things like statins can cause myalgia. So again, we can start looking at, are the medicines the problem or is it something else that's going on? Next click, please. So as I said here, it could be that she is on a high dose of a statin, but she's also on an anastrozole for her breast cancer. And again, that can cause aches and pains too. Next slide, please. So we've had a chat with Mary. We found out about what her goals of therapy are and what her list of issues are, because obviously that's important that we target those when we're doing our medication reviews. It's got to be patient-centered. There's no point otherwise. I mean, we just need to ensure that we're actually thinking about the individual. We're advocating for them. They're not always able to have a voice, so we need to be able to do that on their behalf. So the other things that we'd obviously be looking into are our medical history, her care plan and her goals of care, because that's obviously what would have happened when she came into the home. As I said before, correspondence from other healthcare professionals, anything that the staff or the family might have to tell us about it, any blood test results, because obviously that helps us make decisions around changing medications or ceasing medications. It says that she's got gout. When did she last have gout? If she hasn't had gout for 20 years, maybe she doesn't need medication for gout anymore. Is there any medications we can combine together just to reduce her drug burden and also potentially reduce costs as well to her? Things like with her breast cancer, we know that the treatment recommendation is for 5 years. So when was her breast cancer? Could we stop the anastrozole? Has she been on it for more than 5 years? And we mentioned briefly about her heart failure, how well that is controlled and whether or not we can rein the furosemide dosing in for that. Next slide, please. So with looking at her symptoms and thinking about the things that we need to consider, are the drugs actually helping her? Well, we know that some are going to be helping her. She's got a diagnosis of depression, and moving from an independent home environment into an aged care environment often can trigger depression. It certainly can make people feel very anxious. So I think keeping her on something like hometazapine is not a bad idea at this particular point in time. So we're not necessarily going to be focusing on making changes to all of her medications. We have to do things slowly, and we have to prioritize what we think is going to be the most add the most value initially for her. Things like her insulin are important for her diabetes, her metoprolol and spironolactone for her heart failure, and also her ARB as well that she was taking. I think she was on candesartan. Just having a quick look, because I've got my list here. I've got a cheat list here so I can see what she was taking. And then also the furosemide, if she does need to stay on her furosemide because she's got heart failure with reduced ejection fraction. Then we need to think about, we were talking before about the risk and the benefit. So the risk of her getting a further complication based on her previous medical history. So for example, the statin, I mean, she's 89 years of age. Is she still going to be around in 5 years? But we don't have a crystal ball. We don't know the answer to that question. But the reality is that probably not. And so maybe she doesn't need the statin, or maybe we can at least reduce the dose of the statin. And then, are any of her medications causing her harm? And there's a list here, as we've mentioned before, about some of her medications that could in fact be causing harm to her. Next slide, please. So what did we recommend? As you can see, the highlighted yellow ones are the sorts of things that we potentially could get rid of, not necessarily ceasing straight away. We might want to wean those doses, monitor, wean again, monitor, and then cease. But obviously, these are the sorts of things that we can be looking at making the changes for. So our atorvastatin, lower the dose or stop it. Calcium and vitamin D, a combination product, was obviously a good idea for her as an option. Colchicine, if her gout had been so long ago, then we could obviously cease that. The hydrochlorothiazide I mentioned, the gabapentin, her lactulose, The Macrogol sachets, if she's not constipated anymore, she may well not need those either. Anastrozole, if her breast cancer, as I said, was more than 5 years ago. Iron tablets, if her iron studies were normal. And the oxycodone, she might not need that anymore if her pain was well managed and it was because her medications were causing pain. Next slide, please. So as you can see from this, what medications were ceased. And bearing in mind, as I said, this was done over a period of time. This didn't just happen the following day after our medication review, because it's really important to do one thing at a time and just monitor the individual and see what changes there are in relation to changing their medication regimen. So we did make some changes. We swapped her insulin over to a newer type of insulin, which is got a very short-acting, very long-acting insulin in, just to try and prevent the need for her to have 5 injections every day. We reduced the dose of mirtazapine. So mirtazapine has been shown in the elderly at a high dose, like the 45 milligrams that she's taking, to actually cause more harm than benefits. And so lowering the dose does mean that there's less harm being caused. And again, we managed to reduce her water tablets down, change her docusate and senna just to at night because she wasn't taking the iron tablets anymore, stop the disgusting lactulose, her gabapentin and her hydrochlorothiazide, and the anastrozole because she'd been on it for more than 5 years. So as you can see, over time, we did manage to achieve a lot of changes for Mary. Next slide, please. So really, in a nutshell, to sum up, what did we achieve for Mary? So bearing in mind, beforehand, she was on 18 different tablets. Now she was only on 8. So instead of 33 tablets a day, she was now on 19. Her constipation had improved. She had an improvement in her appetite because she wasn't taking quite so many tablets. She obviously had a reduction in the need for a coloxal and senna. Her insulin was now once a day. Her mood improved because she felt she could socialise more comfortably. She wasn't so worried about rushing to the toilet every 5 minutes, but also her aches and pains weren't quite as severe because we'd managed to see some of her other medications. And because we'd see so many of her tablets that were potentially high risk and increasing her risk of falls, we did decrease her falls risk.
Well, Natalie, I'm just amazed that that scenario is actually real, and I'm sure, as you mentioned before, that many of us would have Marys in our facilities or in our services, and maybe that would be a prompt for you to go back and just check if you do have a Mary, and perhaps get an RMMR undertaken for her, because going from 18 different medications down to 8 would have made a huge difference to her life. But not only that, it obviously would reduce the risks of medication error too, because she's on less medications, I should imagine.
Absolutely.
Yeah. So if we go to the next slide, we're getting to the very end now. So I'm not going to read this to you, but basically the benefits of an electronic medication management system, as we've talked about through this presentation, is that it gives you high visibility on what's going on with your residents. It connects the facility, the prescriber and the pharmacy onto one platform in real time. It can provide you with reports that give you a holistic review of what's going on with your residents within your services and across your services. It can support you with your quality indicators. It can assist you in your psychotropic management and your restrictive practices management. It can support you in antimicrobial stewardship. Next slide, thanks. And you can use the information that you have for high-risk residents at your MAC meeting. You can look at trending data. We know that electronic medication management systems actually reduce your medication errors for non-signage and transcribing issues. So there are many benefits to having an electronic medication management system, and something that if you haven't got one, you should really explore. Next slide, thanks. So we just thought we'd summarise what the keys to successes are from our perspective. And we believe that having a good knowledge of the aged care standards and legislation will support you in medication management. Terms of reference, as I mentioned before, at your MAC meeting should include the RMMRs as a standing agenda item. Having clear policy and processes and guidances on RMMRs. Having information available to consumers and substitute decision makers. And I think, Natalie, we're going to have an information brochure for the families that will go out with our slide deck.
Yeah.
So please use them. Clear role clarity and responsibilities between GP, pharmacists and the care team. Having really good skills and capabilities of the staff who are preparing the information for your clinical or your medication review, so that the clinical pharmacist has a very good holistic view of what's going on with your resident. And of course, adopting technology to support your consumers' health and wellbeing. Now, we know that recommendation 68 of the Royal Commission talks about the use of digital care management systems and electronic medication management systems with interoperability between or with My Health Record. Whilst not mandatory, the government is supporting RACFs to implement medication management systems and adopt the My Health Record by June 23. There was some talk about some funding coming through, but we haven't seen what that looks like. We don't know what the criteria is. I keep searching for it, but it hasn't come through yet. But when it does, we'll put it out there so that you know. So I guess at the end of the day, having an electronic medication management system that intersects with your RMMRs improves the outcomes for consumers in the long run and makes your life easier back at the service. So Natalie, did you have anything else that you wanted to add there?
Just one thing, some PHNs are actually supporting an EMMS depending on which state you live in. So it might be worth, if you're considering an EMMS and you don't currently have one, actually getting in touch with your PHN and seeing if your home will be eligible for some funding around the model of care.
And the PHN is the Primary Healthcare Network, yes?
Oh, sorry, yeah. Yeah, the world of acronyms, you forget, you use acronyms all the time and you forget people don't always know what the heck you're talking about. I would just like to thank everybody very much for coming today and giving up your time. And I hope that you've learned something and that you've got something you can take back into your own homes. And with a bit of luck, we can get our GPs to sign off on the RMMRs and actually see the benefit of them. And we can all work collaboratively together to get the best for our residents in our care, and obviously patients in our home care situation as well, for doing home medicine reviews.
Thank you. Next slide. So I think that does definitely bring us to the end of our presentation. But before you go, if you require an electronic medication management system, or in fact a clinical pharmacist, there's our contact details if you want to get in touch with us for a demonstration or to ask us questions to enhance your knowledge any further. I'm not sure if we have any other questions. I think we brought that one question up. I'll just check in the chat to see before you all sign off. Let me see. Someone's written, sorry, maybe I'm missing the point. The doctor prescribed medications, but the pharmacist reviews. Is it a special review? Because I've seen doctors stopping, increasing and reducing medications. Does it mean a doctor can prescribe amiss? Natalie.
So we're working collaboratively with the GPs. So sometimes the GPs don't necessarily always look at the medications in the same way that we would look at them. And even though they're reviewing the medications, there might be a hesitancy in ceasing them. And we can just come along and help support them in making those decisions by giving them some of the potential issues that we've identified for that resident, and as to why we think it would be of value to change that medication, whether it's stopping it, lowering the dose. Sometimes we might even say to increase the dose, and actually sometimes we might even suggest prescribing medications for individuals. It's really about looking at that person holistically, and then helping the GP make decisions. The other thing that we can do is, so one of the barriers to the GPs taking up our recommendations, which I suddenly remembered I hadn't mentioned, was if a specialist has prescribed that medication. There's a reluctance sometimes for GPs to make those changes because the specialist wrote the medication up for that individual, and they don't want to put or get the specialist offside. I totally understand that, completely understand that reluctance. I work in a multidisciplinary clinic in the hospital, as well as this particular role, and I do see reluctance from GPs, but the reality is the specialists are not ogres, and they're quite happy to allow you to make the decisions independently of what they've done, because you know the person better. And so really what we can help do is support the GPs to make those changes. And I have sent my reviews to specialists to get their buy-in. I've also phoned specialists up again to just ask them, is it okay for this to happen, because the GP might be concerned about it. And I've also phoned up, specialists when I've seen combination medications being prescribed for longer than they should be. So I'm thinking here particularly about antiplatelet agents in combination after people have had some kind of bypass. And sometimes, the specialist has just forgotten about it, or they don't even have the full medication list. So they don't appreciate that what they've actually prescribed could in fact be causing or contributing to harm to that individual. So I hope that answers the question.
Thanks, Natalie. Well, that comes to the end of the questions. That we must have answered everybody's questions as we went along, because there were only those two. But before you all sign off, I would like to take this opportunity to extend to you, from our senior executive at BestMed and WardMM, and from Natalie and myself, a very Merry Christmas and a Happy New Year. And let's hope that whilst we might not have eradicated COVID, that we've contained it, and 2022 will be a much smoother and easier year for all of us. So thank you and take care. See you next year.
Thank you, everybody. Yes, and see you all next year, and have a safe Christmas and New Year.
Thank you.
Thank you. Bye.